Welcome back to the Anja Health Podcast. I'm super excited to have our guest today, Dr. Arielle Bayer, CCRM Fertility. You are a reproductive endocrinologist and infertility specialist. So I'm super excited to have you here today because we've had very few guests that are specifically focused on fertility, but I feel like it's definitely a rising field and we get a ton of questions about it from our audience. So thank you so much for being here.
Well, thank you for having me. I'm excited to be here and to answer all your questions about fertility, postpartum, trying to conceive.
Yeah, awesome. Cool. Well, I'd love to get a bit of a sense of how you got to where you are today and what made you interested in the fertility space in particular.
Coming here to meet you today was like an incredible full circle moment. I just couldn't believe it. So walking to the studio, it's immediately across the street from a place where I sort of started my interest and passion and love of medicine and health. Growing up, I never had this idea I'd want to be a doctor at all. I didn't have doctors in my family and really didn't ever envision that's where my career would go. But at some point in college, maybe my junior year, I got really interested in health advocacy and public health and health education and really helping patients take control of their health. And I got an internship to work at the Charles B. Wang Community Health Center. It's here in Chinatown. It's like immediately across the street. And I passed it walking in here. And it's like, this is such a full circle moment. And I spent that whole summer just organizing a public health day for the residents of Chinatown. And it really made me feel so good to just get health information out to the community and to help increase access to care. And I think it's sort of where the beginnings of where I really could see my career going. Did not do any pre-med or anything until later on when I realized that being a physician and having those conversations with patients and helping them, really take control of their health and be their own best health advocate. That's where I became passionate and decided I wanted to become a doctor. And it wasn't really until medical school. I mean, women's health has always been a huge passion of mine. And I love working with women. And these are very, pregnancy and childbirth and infertility, all these moments in your life are just a very vulnerable time, very isolating time. So I just wanted to be there in those conversations for patients. So that's where sort of my path took me to OBGYN and did my residency in women's health OBGYN.
Yeah, that's awesome. Yeah, my dad's an anesthesiologist and he pretty much always forced medicine on me. He used to get these frogs when I was younger to dissect them in our kitchen when I was like 8. So very different. But it's good that you naturally found it.
It's so funny. I think kids of doctors will have that reaction.
Yeah.
My husband's the same way. His dad did the same thing with frogs to him. And he was like, I would never go into medicine. But yeah, I fell into it and I love it. And as a reproductive endocrinologist and infertility specialist, I do help patients who are either struggling to conceive, trying to conceive, either they are coming to us for fertility preservation. They want to freeze eggs or embryos for the future. So similar to your career in terms of freezing and storage for future options, giving patients opportunities to build families who otherwise wouldn't be able to and need the assistance of IVF or reproductive technology. So that's what we do at CCRM New York.
Yeah, as you know, we do cord blood banking at Anja Health. So I'd love to get your sort of professional take on cord blood banking, especially because you mentioned you have kids. So yeah, I'm curious in your opinion, what are the pros and cons for cord blood banking as an OBGYN?
Yeah, so whenever patients would ask me about cord blood banking, or when I even considered it for my own pregnancies, it's something to consider. It can be an incredibly valuable tool if needed. And whenever it's the same way I counsel patients about freezing eggs or freezing embryos for the future, I think of it as not an insurance policy because nothing's ever guaranteed. And maybe it won't end up working for whatever medical condition, unfortunately, you're faced with. And maybe it won't be the right technology available at the time. So it's never, I can't say an insurance policy or a guarantee, but it will give you an option in the future, right, to utilize something that you wouldn't have otherwise had. So I don't think anyone ever regrets having it because it gives you that chance, that opportunity to use it. But people may, on the flip side, they may regret it if they hadn't done it and they do realize they need it. And in those circumstances, right, it could be devastating if you realize you may have had that opportunity, that option. So if you're planning to have potentially more than one child, right, because banking cord blood is something that you would use potentially for a future sibling of that child. Maybe perhaps there's a family history of leukemia or blood cancer. I think stem cell research is still being undertaken, and there's so much that could happen in the future with stem cells, and it's in a very exciting area of medicine. I don't even understand all of it myself. It's just so dynamic and ongoing, but there may be therapeutic opportunities for having these stem cells, and a sibling would be easier way to find a match. God forbid that sibling ends up needing medical treatment with stem cells. But it's hard to know because maybe you're not going to have that other child, so it might not make the most sense. And maybe the other thing is like, and you had mentioned this in the past, just finding a match for a child who needs stem cell therapy is sometimes difficult based on ethnicity.
Right.
And so doing this for your family personally can help with that, because finding a match, if you're not from a really popular ethnicity or combination of ethnicities, it can be really hard to find the right match. So that does give you that opportunity. But hopefully many families won't end up needing it or end up using it, and then you have spent resources and money on that. So it is something to think about if you do have the resources to do it.
Yeah, I'm curious if you did cord blood banking for your kids.
Yeah, in fact, I did consider it. I asked my OBGYN as a patient. I wanted to know her opinion as well. I asked friends. My coworkers. I was in OBGYN residency at the time when I had my children. My first child, I did not. I decided, not sure yet if I'm going to even have a second child. I'm fortunate that I don't know of any inherited diseases that run in my family that would necessarily require treatment with this. And also, by the time, if I did have a second sibling, I didn't know the age. I didn't really understand how it would age. That technology would be able to last for when that child ends up needing it one day. If they need it later in life, maybe that amount of stem cells might not be enough. So I didn't end up doing it for either of my children, but I do make sure to counsel patients whenever they ask me.
Yeah. Okay, awesome. Another part of cord blood banking that we get a lot of questions around and that I love to get OBGYN perspectives on is delayed cord clamping, because there's kind of a misconception that you have to choose one or the other, cord blood banking or delayed cord clamping, but you can do up to 2 minutes of delayed cord clamping. But I know even it seems like the concept of delayed cord clamping is relatively newer. Like we've had some OBs on the podcast that have mentioned that they've only really started to do it in the past 10, 15 years. So yeah, I would love to get your professional opinion on delayed cord clamping and how it relates to cord blood banking and just deciding that as part of your birth.
Yeah, I think delayed cord clamping has always been a part of my training, I guess, because I am part of the generation of doctors who absolutely allowed for delayed cord clamping as long as the environment allows it and the patient is safe and there's no emergency happening at the same time. And when things are in a controlled environment, of course, you can let the clamp of the cord get delayed, and we would always feel for the pulse and wait until the pulse was no longer really palpable. You could wait exactly 2 minutes even and without any consequences and still collect a good amount of cord blood afterwards. So we would routinely do this in the hundreds of deliveries I did in residency. And yeah, I think they're not mutually exclusive. You can have both things. And as an OBGYN, of course, the safety and health of the patient and the baby are of the utmost importance. So if there is an emergency situation going on, if other things need to be controlled, then sometimes the clamping of the cord must be done just to necessitate other things going on.
Right. Do you have opinions for how long delayed cord clamping should go on? Because we get some backlash on social media when we post about the 1 minute rule even. I know ACOG kind of has a around 60 seconds to 5 minutes recommendation. But we've also gotten opinions around lotus births, for instance, that people comment on social media. So yeah, I just generally like to get your professional take.
While I understand there are patients who want to request a lotus birth and to maintain that connection to the placenta as long as possible, my understanding was that once the blood flow is no longer actively pulsing and giving blood flow to the baby, then the benefits are very minimal. So I'm comfortable clamping the cord, with the absence of the pulse. Yeah.
Okay, awesome. Cool. Well, I know you mentioned you have some questions for me around cord blood banking. So yeah, I would love to answer now.
Yeah. Well, so tell me, I've heard of private cord blood banking, the last, since my OBGYN training, and patients are always asking me, tell me what Anja does differently, or how what makes it special. Would love to.
Yeah. Well, so our main advantage as a cord blood bank is affordability. So we have different payment plans. Our most popular option is to do the 8-year monthly interest-free payment plan that we have. So there's no credit checks required, and it starts at just $49 a month. And there's no upfront fee except for the kit, which is $199. But typically with cord blood banks, they require like $1,000 upfront or so, and then you pay annually for life. But ours is only for 8 years, and that's for either a 20-year storage payment plan or a lifetime storage payment plan, so that they aren't held accountable to a payment for life. And yeah, it starts at $49 a month, so we can reach a sort of lower income consumer than the typical top 1% that I think a lot of people assume are the only folks that can cord blood bank. And our other big difference is that we bank the placenta. So we're able to capture stem cells from the placenta and not just the cord blood and cord tissue. And that's also our most popular option, is to bank all three, so parents can get the maximum volume and variety of stem cells.
And then I guess my other question is, in terms of how long do patients typically keep their cord or their stem cells banked for? Because my understanding is once a child is of a certain age or size, perhaps those stem cells may not be enough volume-wise to treat them. Do you know? I'm still learning about this.
Yeah.
What your thoughts are about that?
Yeah, definitely. Yeah. Well, so we offer the lifetime storage payment plan, so folks can pay up to for a lifetime or store for up to a lifetime, but they can also do the 20-year payment plan and then renew. So generally we find that parents are interested in storing for life, but yeah, they don't expire and they can potentially be used at any point. But yeah, you're right. At certain points, if for instance, the child is basically an adult or like fully grown in a sense, then just cord blood alone could potentially be too low volume, in which case they could combine it with what else they've stored. So cord blood and placenta stem cells, for instance, we have a couple case studies on our site that show when cord blood and placenta has been used for the stereotypical cord blood use cases. So for instance, leukemias, sickle cell anemia. So yeah, I think that's why a majority of our clients will bank all three, because then they can ensure that they have sufficient volume for any stem cell treatments. Yeah, and I know it seemed like as you were chatting about cord blood banking, you were thinking that maybe it could only be used for a sibling, but it can be used for the baby themselves as well.
Oh.
So yeah, just something to note. Well, yeah, I'd love to delve deeper into sort of secondary infertility, how folks think about their next pregnancies, because I know you mentioned that that's sort of an interest of yours and you get a lot of questions around it. So yeah, I would love to delve deep into that. So thinking about when someone has their next pregnancy, so a second or more child, when is it safest to start trying again for that child? And when should they start to look out for signs of potential infertility the second time around?
Yeah, I mean, I think thinking about how to space out siblings or when to start trying again for your next pregnancy for sort of optimal health and recovery from your last delivery, generally OBGYNs will say an 18-month interval between giving birth and getting pregnant again would be ideal. But in this world of, struggling with infertility, women who are getting older and worried about their sort of reproductive age and how difficult it might get if they are 18 months older, it is acceptable, of course, to get and possible to get pregnant sooner than those 18 months. If you've had a certain kind of delivery, like an emergency C-section or a C-section that you need to really heal from that surgery, your OBGYN may recommend, at least, 9 to 12 month pregnancy interval, just to allow your body to really recover and heal, just to be a safe, and the risk that most patients are worried about the most in between, if they do require a C-section again, or if they've had a prior C-section, is the risk of the uterus rupturing, right? That scar on the uterus not fully healing. So, the safest recommendation is an delivery interval of 18 months minimum.
Okay, awesome. Yeah, I know there's the concept of Irish twins where folks have really, really close intervals. So yeah, I'm curious if you find that it is generally easier to get pregnant the second time around, or if folks tend to have a higher incidence of infertility or anything like that.
I think as an infertility doctor, I see it both ways. I
Yeah.
see patients who really struggled to conceive with their first child, required fertility intervention and treatment, and just assumed that it would be equally as difficult, if not harder, the second time around. But oftentimes, it is really hard to track your cycles. If you are breastfeeding, if you are postpartum, your cycles may come back different in a different pattern than previously. And so we do see a lot of surprise pregnancies or kind of unplanned, unexpected pregnancies the second time around, and patients are shocked to see, wow, I thought this would never happen for me, and that's, could sometimes be a relief. It could sometimes be a surprise, all a mixed of emotions.
Yeah.
But we do see that as often as we see the opposite of that, and a greater struggle to get pregnant the second time around. And that could be due to a variety of factors. We call it secondary infertility because you may not have had infertility the first time around, but this next time around, there are new issues that came up that were not there before.
Right. Yeah, one of my friends was an Irish twin, and they were actually their mom raised them as twins because they were so close in age. So they believed that they were twins until they were like 11 or 12.
Yeah.
When they realized they weren't.
And we see it even some patients who are taking the journey to parenthood through a gestational carrier, right? And
Yeah.
they may have an ongoing pregnancy occurring, but maybe they matched with a different gestational carrier, or they got pregnant naturally themselves by surprise. And so they may have children that are super close in age, completely unplanned. Just that can also occur.
Right.
These sort of Irish twins, as you call them, because they're just so close in age, but actually through different carriers.
Okay. Yeah. I feel like, didn't Chrissy Teigen have that happen with her third and fourth child?
Thanks.
Yeah. I think they're like 6 months apart or something like that.
Yeah.
Okay. Awesome. I know you mentioned kind of depends on the previous pregnancy that you've had, but is there generally a recommended window or kind of like a blanket recommendation that you have between having one child and the next?
Yeah, I think, like I mentioned, to sort of fully like heal from postpartum, to feel, as strong and healthy as possible, and to minimize risk in the next pregnancy, that 18-month window is generally recommended. But but it's not a hard and fast rule because of circumstances, or someone struggling with infertility or concerned about age, they may try sooner than that. But it's always good to talk to your doctor about that and know what sort of the personal recommendation for your own situation is.
Okay, awesome. And if you want to choose the gender for the next baby, what are your options?
Yeah, I mean, we see patients all the time who are interested in what we call family balancing, or if they have a sex of one baby and they're interested for their next child to be a different sex. We can do this through the process of IVF. So IVF, when you create embryos, you have the opportunity or the ability to do a biopsy of that embryo to understand the chromosome content, the chromosome makeup of that embryo. And this the purpose of this was to really help reduce the risk of miscarriage or abnormal pregnancies. For those who are struggling with infertility, this is a recommended treatment and sort of standard of care these days to do that embryo biopsy. The information you get from an embryo biopsy is just a chromosome screening. So understanding for that particular embryo, does it have a full set of chromosomes, 46, right?
Yeah.
23 from the mom, 23 from the dad. And the other part of information, the other piece of information you get from that biopsy is if it's XX a female or XY a male. So if you do make embryos with IVF and you do have more than one embryo available, you may have that opportunity to actually choose which sex you want to use in your transfer. Some patients will come specifically for that purpose, and they'll do the whole process of IVF to get that information. And some patients are doing IVF for other reasons, and then when given the chance, they have two equally beautiful embryos, and one's a male, one's a female, then they may ultimately say, let's try this one first or that one first.
Interesting.
Yeah.
What typically motivates family balancing?
It's such a personal thing.
Yeah.
Yeah. I mean, I think, we know sex is not gender. It's just the biological, reproductive organs you're born with. So it's such a personal decision.
Yeah.
That's something you're interested in.
Yeah, that makes sense. That's interesting. Yeah, because I haven't seen a ton of content around the idea of family balancing, but yeah, it's interesting to hear about.
Yeah, it's legal in the United States. And I think when you're doing IVF anyway, you're going to get that information. That's a some patients don't want to know. Some patients say, just put in the best embryo. Don't even tell me what it is. I rather not know. And so, you as the patient, these are your embryos. You can choose if that you want that information or not.
I see.
In other countries, it's not every country. This is a legal thing to do.
Okay, interesting. And if you want to have twins specifically or multiple births in general, is there a way that you can help predict that or increase your chances through IVF or anything like that?
Yeah, it's really interesting you asked that. A lot of patients do come with that exact question. Prior to the days of embryo testing, before we were able to get such a good quality embryo with normal chromosome count, so the sort of the earlier days of IVF, right, more than 15, 20 years ago, you didn't know which embryos were going to work and which didn't. It was really related to the age of the woman. It was the success rate would be just completely related to the age of her eggs. So doctors would put in more than one embryo at a time. It was very commonplace to say, okay, if this woman is in her late 30s, if she's 40, let's just put in a couple embryos, whatever she was able to make, and hopefully one of them sticks.
Yeah.
But nowadays, with the advent of genetic testing, we know that a beautiful embryo, good quality embryo with normal chromosome count has up to a 70% chance of a live birth, which is really, really high chance of success. So it is recommended. This is ASRM recommendations. National organization really recommends putting in one embryo back at a time. And that's really to not just protect the health and safety of the mother, because twin pregnancies we know are high risk. They do increase your chance of gestational diabetes, preeclampsia, hypertensive disorders, increased need for C-section. It also puts the fetuses and the babies at risk because there's an increased chance of preterm delivery, increased chance of twin transfusion syndrome, unequal sharing of placenta blood, and it can be or even just think of space available in the uterus. Right? There's an increased risk of intrauterine growth restriction, low birth weight. So all of these reasons, we would try to avoid a twin or multiple pregnancy if we can. With that being said, there is always the chance that an embryo splits and you get identical twins, right? That is sort of out of our control. It's a low risk. It's as low as it is in the general population. It shouldn't be much higher than that. But that is always, it's possible that people do get twins. We try not to purposefully get people pregnant with twins if we can avoid it, just for their health and safety.
Okay, interesting. But if people still want to advocate for themselves to have twins, do you support that?
It's a really personal conversation between a patient and a doctor, if that is something that they're going to pursue. And so I always have that conversation on a one-on-one basis with the patient.
Yeah. Okay, interesting. Yeah, I don't know if you know Francesca Frago and Jesse Sullivan. They're
from reality TV.
Yes, from
I love reality TV. I know what you're talking about. Yeah, of course.
Yeah, they Francesca was on quite a few Netflix shows, and then she got engaged to Jesse Sullivan, who's a trans man and has had a baby previously prior to transitioning. And so I think they used Francesca's eggs and the previous baby's father's sperm. And then now Francesca is pregnant with twins. But they documented their whole journey really, really intimately, like down to like how they chose the gender and what they were thinking in terms of like which embryos to choose. And they really documented the full journey. So it was really fascinating to watch, especially because, Jesse's trans. Like, I think it's such an unconventional perspective into IVF.
Yeah, and fertility treatment and fertility technology can just build families in really special and unique ways like that. So these, it sounds, I don't know the whole details of the story, but it sounds like these children are going to be genetically siblings.
Yes.
Which is incredibly special for this family and a wonderful opportunity.
Yeah, definitely. Yeah. So they just announced that Francesca is pregnant with twins. So I guess as you were speaking about that, I was thinking if they purposefully chose that or if it just split.
Yeah, if it was IVF, yes, like that is a conversation they must have had, with their doctor, understanding the risks of a twin pregnancy. Another way that in fertility treatments that could occur is if you do a treatment called ovulation induction for insemination treatment. So if they were doing, and I don't know their personal story or their medical history, but if they're doing insemination, basically with the woman's natural cycle for her body to release that egg, or we actually help induce the ovulation or release release of that egg with some medications. There is a slight risk of twins if you are growing more than one egg at a time, right? So with ovulation induction, you're taking a pill to help assist with that growth of that follicle and that egg to release it at the right perfect time in the month. And if, we typically as fertility doctors will monitor it with ultrasounds and blood work to make sure that it's not more than, 1 to 2 eggs maximum, because it does increase the risk of twins or triplets and so on if there are more than one egg released at one time.
Right. Okay. Interesting.
So, I don't know their story though.
Yeah.
They got pregnant.
At what year did it start transitioning between, I know you mentioned previously people would just kind of implant as many embryos as they could based on the age of the mother. Do you know when that transition happened? Because a lot of my friends who are twins, they're pretty much all IVF babies.
So in 2017, ASRM, the American Society for Reproductive Medicine, came out with these guidelines to really recommend single embryo transfer when embryos have been genetically tested previously. So that changed so much in the world of IVF. So yes, in your generation, children born in, of course, the 90s and in my generation, the 80s, when IVF was first starting, and even the early 2000s, there are many multiples from IVF. Even though the guidelines came out in 2017 originally, for doctors and practices and clinics to really adopt those and to put them into practice, it takes time, because when something is sort of a standard procedure, it does take several years and over time for things to really become normal practice, and for doctors and patients to both come to an understanding of why this is the safest and makes the most sense. But nowadays it is much more rare to see that.
Interesting. Awesome. So for folks that are looking to have their second child, I was wondering what your top tips are for preparing for that pregnancy, and especially if they've encountered infertility in the past.
Yeah. So for their second child, some things that you may want to keep in mind is it depends how long it's been since you tried to conceive the first time around, but first of all, seeing your OBGYN, making sure you're up to date with your routine healthcare maintenance. You're up to date with your most recent pap smear, your mammogram if you're old enough to have one, or have a family history for breast screening. You should be up to date with that. The preconception labs or prenatal labs that include carrier screening to see if you and your partner have a match for any like autosomal recessive genetic conditions. Those tend to update every few years, and there's sort of larger and larger panels available. So you may want to update that with your partner and see if the newest blood test for carrier screening, is available for you and your partner to take. It's something that not all couples want to do, or choose to do, but we make sure to offer that to every single one of our patients before trying to get pregnant. Your immunity labs, measles, mumps, varicella, all the sort of those shots you get in childhood, those all wear off with time. So just making sure you're up to date with all of that. You don't need any booster shots, sort of general health, taking care of your general health, and if there's anything that you need to follow up with the doctor to get under control, if it's blood pressure, thyroid disease, asthma, anything, you just want to be in really the best health possible. Depending on what occurred in your last pregnancy, you may have certain circumstances you want to just check out and make sure that everything is okay before trying to conceive for your next child. But as long as you have no history of infertility, you can try to conceive just right away the way you did the first time, whether that was tracking your cycle and having timed intercourse, just having intercourse, throughout the month on a regular basis. But that is sort of the place to start. But things that can change over time that we include in like a general infertility workup, if you do have a history of infertility or you want to kind of just check all the boxes and come see an infertility specialist, some things that we do look at are from the male side, a semen analysis. It's just a semen sample and looking at the numbers and parameters of your semen analysis. We will check to make sure the fallopian tubes are open and working so that you can get pregnant naturally with a dye test called an HSG. It's like an X-ray test of the pelvis to make sure that your fallopian tubes are open and that there's nothing in the uterus that could be blocking a pregnancy, like a new fibroid, some scar tissue, a polyp. It's sort of a test that we can do beforehand. Sometimes with abdominal surgery or, history of infections, you can get, or endometriosis, you can get scar tissue around the fallopian tubes that can create a blockage. Other things that we do as fertility doctors, we can just sort of see where your ovarian reserve is at your age. looking at your ovarian reserve testing, you may hear a lot. It's really just to look at the quantity of eggs available that month, and doing an AMH blood test to see sort of where you fall in a sort of a normal quantity range. It's not going to help predict how easy or hard it will be to get pregnant, but what it will do is help you as a patient understand where you're sort of where you fall in terms of your chronological age. Are you in sort of the expected range for your age? Are you a little bit look like your numbers are a little bit lower for your age, a little higher? And it just can kind of give you a sense of where you are in terms of quantity of eggs. But again, it doesn't help predict your ability to get pregnant like some of the other tests can do.
I'm curious what the typical causes of infertility are, especially if it's your second time around or more getting pregnant.
Yeah, I think the most common cause that we see the most is really age-related fertility decline. You may have not had any difficulty conceiving your first child, but now it's several years later, or even more years later, if depending on how much time you're putting in between the children. But your eggs are really the best quality when you're younger, when even before puberty, right? They're the highest quality when you're really, really young. And every year of your life, the quality of your eggs does decline. And if you think of it, it's such a fragile cell with just really like half the amount of chromosomes compared to any of the other cells in your body. It's super small, super fragile. And over time, the machinery of that cell is not going to work as well and not work properly. So there is an increased chance for mistakes to occur, for failure, fertilization, of pregnancy failure to occur. That's why miscarriages are more common when you're older. So we do see struggles to get pregnant just by unfortunately age alone.
Okay. Interesting. I know some of the causes of infertility at the second time around too could be just a general hormone imbalance. What generally causes that, and how can you solve for that?
Yeah, I think there is a lot of questions about hormone imbalance and what's going on with my body postpartum. Some of the most common things that women will experience postpartum is really just this huge drop of hormones that you're coming from a state of pregnancy and postpartum, things sort of plummet really fast. So some symptoms people might experience are like night sweats or hot flashes, vaginal dryness, being incredibly fatigued. Of course, you have a newborn baby, but the sort of drop in estrogen can be just very, very off-putting and can cause like a lot of physical symptoms, especially if you are breastfeeding. And not all women breastfeed, but if you are breastfeeding, it does sort of keep all of the other hormones, estrogen, really, really low and suppressed. So you do feel those effects of low estrogen in your body, almost as if you're not menopausal, but the effects feel as if you are in menopause from such low hormones. So that hormone imbalance can definitely hinder your ability to get pregnant and have natural cycles. And so immediately postpartum, and when you are breastfeeding, a lot of women will not get their period, right away to come back while they're breastfeeding.
How long after birth do your hormones take to rebalance?
It is different for everyone. It depends how long you decide to breastfeed for, but it can take several months. If you're not breastfeeding, it can take several months for your body to just get back to its normal cycles. Cycles may change too with age. So it's sometimes hard to tell, is your cycle changing just because you're getting older, or did it just really change after giving birth? But you might fall into like a new pattern. But I'd say definitely at least several months and even longer if you do decide to breastfeed.
Okay. I know you mentioned PCOS earlier. If you have PCOS or endometriosis, are there any specific precautions you should take when looking at a second or more pregnancy?
Yeah, I think if you know your own diagnosis of PCOS or endometriosis, they're very different diagnoses, but they can impact your fertility. With PCOS, for example, you may need fertility treatment to help you ovulate or to help you get pregnant in the future. So if it's a condition you already know you have, you may consider, depending on your family goals and what size family you want one day, either creating embryos for future use or freezing your eggs for future use, so that, because you may end up ultimately deciding to go the route of IVF later on when you are ready to have children or your second or third kid. So I always recommend, if you have these diagnoses, to come see an infertility specialist, or just to have that conversation and discuss your future plans and goals. And the same goes for endometriosis. Endometriosis is one of those kind of, unfortunately, can be kind of sneaky. You could just be experiencing like cyclic pelvic pain or really bad PMS or cramping or pain. But unfortunately, if depending on the location of the endometriosis or the extent of the endometriosis, it can make it harder to get pregnant. Speaking of reality TV, there was another reality TV castmate from Bachelor this season who did talk about her experience with endometriosis and how it did make her very anxious and nervous about future fertility. So I always recommend just see a fertility doctor, even if you're not thinking of having kids right now in this moment, to really understand where your ovarian reserve is. If you do plan on having children in the future and how many you hope to have, maybe embryo banking or egg freezing is a great option for you. Just to, like I said, it's never an insurance policy, but it can give you options for the future.
Okay. Yeah. Thinking about IVF or even like embryo and egg freezing, would it potentially be easier or just change the experience if you've done it before? For instance, if you had no trouble conceiving for your first baby, but now for your second baby, you're experiencing infertility and looking at IVF or anything like that. Yeah. Just how would it change the experience to do it for another child?
I always talk to my patients about their mental health and how they're faring with this whole process. I mean, no one really ever wants, and no one wants to come see us, right? If you're struggling or having a difficult time conceiving, it's not like a good experience, right, to come and see a fertility doctor. So I just want to make sure that they don't feel isolated and alone and have support that they need. So I think seeking out a therapist or a mental health counselor or a support group, resources, or even a friend who's been through it so you don't feel as alone and isolated. If you didn't experience fertility and it was really easy, so to speak, for you to get pregnant in the past, and now you're now encountering a whole new world of fertility treatment, it can be so challenging. And also, like you asked, how is it different the second time around if you have a child? Not only that, you're taking care of a child, a young kid, and there's just so much on your plate. You're really trying to balance a lot of things, your appointments, the kid at home, and your job, whatever is going on in your life. It can be a lot. And so I do always check in to see if they need resources to speak with someone who we have incredible therapists that we recommend, who really, this is their real specialty and only really meet with patients who are going through these struggles.
Right.
So they don't feel less alone.
Yeah. Okay. Awesome. I was in Y Combinator, which is a startup accelerator for the company. And there was another company, Luna Joy, that they help match postpartum therapists or it's just kind of general like fertility / pregnancy related therapists as well. So yeah, it's a really powerful mission. I know they've been growing really quickly because there's such a need for it. And
such a need.
Yeah. As I've been chatting with OBGYNs about it, and even the Luna Joy team, like they always mention that the doctors are always just like, I literally don't know who to recommend. Like, there's so few. So, yeah.
And there's such a need. I think it's not just, also keep in mind, not just for the patient who's trying to get pregnant, but sometimes the partner as well, because they feel sometimes very powerless too.
Right.
In a situation, fertility, it can be a male factor, it could be female factor, but the stress it can put on couples. So a lot of them do need couples counseling as well. Just going through this is really hard. So having support is incredible.
I'd love to move into the birth process. I know you don't focus as much on birth, but I feel like there's a lot of conceptions around birth for your second or more child, for instance, that it could go faster, things like that. So I'd love to get your take. So yeah, is a second baby usually a faster birth?
Yeah, I mean, it so depends on the patient, but if you had vaginal delivery and your body went into labor with your first child and you're pregnant with the second, it is quite common that it does occur quicker the second time in terms of labor time and ability to deliver. The time is shorter than the first time around. It's almost like your body, just has already done that process once. And so things can happen a lot quicker. So we would always tell our patients in residency, like, come back to the hospital a lot sooner than you thought you would have. You don't sit at home counting contractions for hours when it's your second or third kid. It could happen a lot quicker and you can dilate a lot faster. But in terms of if, that was not your birth history and you had a different mode of delivery, I mean, it doesn't necessarily always mean that you're going to go into labor faster or have a faster delivery.
Yeah.
It depends on the patient.
But okay.
We've definitely seen that.
I've seen that second babies tend to weigh more as well. Is that true?
It's all over the place. I don't know if there are statistics that show that's the more common. I think usually what we would tend to think is that the sort of predicted birth weight of your child is probably going to be similar to your last pregnancy, but it can change. It can be different. There's different medical conditions that could arise in pregnancy that cause different birth weights. Like, for example, women who have gestational diabetes tend to grow bigger babies with different fat distributions. And that's just based on the sort of sugars in the blood that can cause that larger birth weight baby. Women who have like hypertensive disorders like preeclampsia can sometimes have growth restricted babies or smaller babies. So, it's really it's all over the place depending on your health conditions. Yeah.
Okay.
Hard to predict.
Okay. Awesome.
Yeah.
What about gender? If you've previously had a certain gender for a baby, or a certain sex for a baby, does that generally predict future babies? Like,
people will say like, my family only makes this, and I only make boys, I only make girls. The truth is, like, scientifically, each time you conceive, it's a 50-50 chance each and every time. Yeah. So yes, while there are a million like myths out there and wives' tales, like I think it's 50-50.
Yeah. Okay,
funny.
Awesome. I know we chatted a lot about second pregnancies, but is there any way to sort of predict potential infertility that you might face for third and fourth pregnancies? Or is there kind of anything to look out for there if you've experienced infertility in the past, or even if you haven't?
Yeah, I mean, certain things will cause infertility, unfortunately, like certain medical treatments like a chemotherapy or certain surgeries can lower your fertility if it involves your ovaries, or men if they have any kind of, God forbid, a cancer, surgical emergencies that can affect their sperm count, certain medications that they might be on. So, things do change in life and things change over time. So that's why, can never predict fertility often in the future. And when I have conversations with my patients about fertility preservation and freezing eggs and embryos for the future, it's similar to the way that you think about your cord blood banking. It's not that it's going to guarantee anything, and it's not an insurance policy, but it's giving you options for the future that you wouldn't have otherwise necessarily had. So just giving you these opportunities, younger eggs, healthier eggs, hopefully more eggs than when you're older and later in life, and may unfortunately experience things in your health that will make it harder.
Right. I know there are a lot of kind of negative stories that tend to be shared around fertility struggles. Like you said, you don't want necessarily a lot of people once people do visit you, they're generally kind of already facing a struggle. But I'm curious if you have any patient stories that you're allowed to share that kind of feel uplifting or just positive in general that you like to give as a sense of promise.
Yeah, I do. We do see that. I think when you're facing infertility, right, it can be incredibly difficult and hard. And I do have patients often come to us who've already been previously at a different clinic or a different doctor and had a negative experience. I think when you're trying to find the right doctor for you, the right clinic for you, it's so important to make sure that your doctor really listens and hears what your goals are, your concerns, ideas you have. I do think patients sometimes come to me with the best ideas about their own health. They know themselves better than anyone, right? So I think finding a doctor that's going to really listen and be open to ideas and things that they may not have even thought of on their own, and just partnering with your patient, right, to find the best treatment plan forward. Yeah, I could think of many uplifting stories. My best days are in the office or when I say goodbye. They're bittersweet because I'm going to miss my patients. But when they graduate and I'm sending them off to their general OBGYN with a healthy, happy pregnancy at the end of the first trimester, it's the best feeling ever. I get to know these patients incredibly well. I often meet other members of their family, siblings, parents, of course, their partner. If they have a partner, you get to know each other quite well, unfortunately, fortunately. So it's an incredibly rewarding experience. I think keeping hope is hard, and, taking it step by step and really just trying to focus on small wins and a little, just day by day sometimes can help get through it.
Yeah. Well, so I know you're based out of CCRM, which is here in New York. But yeah, I would love to know more about where folks can find you and also what makes CCRM different.
Yeah, so CCRM New York is the New York fertility office for the CCRM actually stands for the Colorado Center for Reproductive Medicine, because the an original clinic that was founded by Dr. Schoolcraft is actually in Colorado, in Lone Tree, Colorado, and that was the first fertility practice that he started. And now we have grown. There's more than a dozen CCRMs around the country, so we're a network of clinics that do everything from fertility treatment treatments, fertility preservation, third-party assisted reproduction. We do everything related to fertility. It's a place that I was drawn to because of the numbers, right? The quality of the lab is incredible in terms of when you're doing IVF, you're really, it's so important to know more information about the lab and the success rates of the lab and the quality is of the utmost importance. So I'm really honored to work alongside an incredible team of embryologists in the lab who really make the magic happen, because without them, we couldn't do what we do. But you can find us on CCRM's website. CCRM New York is here. It's in Midtown Manhattan. There are 4 doctors, Dr. Levine, Dr. Talabian, Dr. Notman, and myself. And yeah, we're happy to help and take care of your listeners.
Awesome. Well, yeah, thank you so much for being here today. I think this was a great episode. Yeah, we haven't had any focus specifically on second or more pregnancies, and especially infertility, and that realm of a pregnancy journey, I think, is so undiscussed because, yeah, if they did not experience infertility previously, they may even feel kind of more alone. So, yeah, I really appreciate you being here today.
Thank you. And thanks for teaching me so much about what you do too. And
yeah,
look, I think it's amazing.
Thank you.